Hello, this is Dr. Bhomik. Today, I'm going to talk about chronic lymphocytic thyroiditis, also known as Hashimoto's thyroiditis, and probably most scientific name should be autoimmune thyroiditis. In my last lecture, I talked about goiter in adolescent, how to examine and how to evaluate them. So it just makes sense that today I talk about autoimmune thyroiditis. And the first of all that I like to talk to you about the prevalence of this condition. And we all know, anybody who practice medicine, that Hashimoto's thyroiditis is the most common cause of thyroid dysfunction in a pediatric age group as well as adult age group. The highest incidence of Hashimoto's thyroiditis or autoimmune thyroiditis is around third and fourth decade of life. However, in pediatrics, it is the number one cause of thyroid dysfunction. This condition may present with or without goiter in children and adolescents. However, in adult, they usually have goiter almost all the time. Now, if you want to go and start looking at the prevalence of thyroid antibodies in school children at random, then one would find about 1 to 2% of the school children have thyroid antibodies positive for autoimmune thyroiditis. In our own series in Michigan, we found about 3% had positive thyroid antibodies. But if you follow them longitudinally, then you will see is about 1/3 of them will develop hypothyroid. And the rest of them, and in serial measurement of the antibody, they will show that it has disappeared. So body takes care of itself, but about 1/3 of them will develop hypothyroid condition, and as I mentioned before, is the most common cause of hypothyroidism in a pediatric age group. And epidemiology is no surprising, and most of the thyroid conditions are more prevalent in female. So here is about 4-1 or 3-1 depending upon the series you are reading. And also some studies have shown, and it is actually pretty much accepted, that Caucasian has got somewhat more incident than other race. Now, if you are looking at the HLA typing of a given person, histocompatible leukocyte antigen, which is on chromosome short arm of the chromosome number 6, and if they have DR4 and DR5 in their haplotype, they have an increased risk of developing autoimmune thyroiditis. However, if they have HLA-DR3, there is an increased risk of atrophic variant, where they usually won't present with goiter and the gland will fibrose before you can actually examine or find them. And about 1/3 of the patient will present to your clinic may have family history. That means somebody in the family, mostly the female member of the family, may have autoimmune thyroiditis. And interestingly, that does not have to be chronic lymphocytic thyroiditis, but it could be a Graves' disease also. Now I'm going to use this slide, and I found it is very informative, and I have borrowed this slide from Dr. Stephen LaFranchi from Oregon Healthcare Science from one of his lectures, and I borrowed this slide, and I found this is probably the best way I can explain to you the pathogenesis of chronic lymphocytic thyroiditis. One easy way to remember the autoimmune thyroiditis or lymphocytic thyroiditis, the problem with T lymphocyte. On the other hand, when I'll talk to you about the Graves' disease, I'll tell you it is more problem with the B lymphocyte. So T cell and B cell. So if we go straight down, what is happening in result is the defect in cell-mediated immunity, and this directly makes forbidden clone of T lymphocyte directed against the thyroid antigen, and that is what caused the thyroid damage. And when the thyroid is damaged, the inside cellular component like microsome, thyroglobulin comes to the circulation, and anything which comes to the circulation is considered as a foreign body, and the body produces antibody against them. So that's as simple as that. So body, you will find anti-thyroglobulin antibody, antimicrosomal antibody, which is also known as thyroid peroxidase antibody. Now let's see what is the big problem here. Why this thing happened? Well, biggest problem is here, immune surveillance. Being a retired military physician, I like to explain this one by using this immune surveillance is considered as the spy plane that's flying over the enemy's position and try to locate the problem area. And once they locate them, they call the responsible person or the fighter plane. They will come and bomb them, or they will attack them and destroy them. So biggest problem is the immune surveillance. It fails. It really did not do its job, which it's supposed to do, and that's how they protect us. And there is genetic predisposition is also one of the part, and they fail. As a result of that, suppressor T lymphocyte, which is supposed to destroy these bad guys, destroy this mutated lymphocyte, they fail. So whole system here is the failure is immune surveillance, and as a result of that, all this thing has happened. And so this is probably the most simple way that I can explain to you, but I tell you, this is not as simple as I have explained to you, but this will give you a better understanding than what we are talking about. All right, now let's try to classify this autoimmune thyroiditis. Okay, now one is juvenile autoimmune thyroiditis that occurs usually less than 10 years of age, and these children are the one who present with growth failure, severe signs symptoms of hypothyroidism, and also sometimes because of the high TSH they might present with pseudo precocious puberty. I will urge you to look at the case study 1. That is the first case study of this series, or the first lecture of this series, and the first one is juvenile autoimmune thyroiditis. There I have explained this condition a little bit in more details. Then after that it comes the Hashimoto's thyroiditis. In pubertal children, this is the most common presentation. They isn't around pubertal, peripubertal or pubertal age or post-puberty, just a goiter and hypothyroidism. They usually present, they are referred to your clinic or referred to you because of the goiter, and then you find either they are hypothyroid or euthyroid. And the fibrotic fibrous, the one which is associated with DR5, this one is also very, very aggressive. The process goes so fast that a goiter, if there was ever one, is not detected. And the whole gland goes through the fibrotic and then atrophic form, and these are the one again present with juvenile autoimmune thyroiditis picture. So the fibrous variant is the very destructive, and they all present with severe hypothyroidism. Now, the juvenile autoimmune thyroiditis, that is less common than the typical Hashimoto's thyroiditis we see in the pubertal and post-pubertal age. But this is also the most common cause of goiter in the first decade of life. Although they might present with fibrotic or very destructive form, but not all of them. Only they have ACLA DR5 or 3 in their haplotype, they probably will be that kind, but still majority of them will present with goiter. So there is a diffuse soft thyromegaly, and hypothyroidism may not develop right away, it might take a little bit longer time. If you look at the thyroid gland biopsy-wise, you see the lymphocytic infiltration, and from that the name came lymphocytic thyroiditis. And occasionally you will also see the eosinophil. Usually, characteristically, there will be no lymphoid follicles. Hartley or Ashkenazi cells is absent. There is no, these cells are characteristic of Hashimoto's thyroiditis, and there is no regional lymphadenopathy, which in adult patient is seen rather commonly. So these are the things that interesting to note before we go to the next slide. And again, as I have just mentioned, there is the fibrotic form of the adolescent present with myxedema, growth retardation, delayed puberty, and as I have already said, the goiter may have been there, but it has been, the process has been so aggressive, the gland has become fibrotic and eventually become atrophic. So the fibrotic variant is the one is in adolescent. It is also seen in adolescent, not only that in juvenile, I'm less than 12 years of age, but again, although majority of them will present with goiter, but some of them may have fibrotic variants, and especially if they have ACLA5. So majority of the patient with lymphocytic thyroiditis present with goiter, but no hypothyroidism. So this is we call euthyroid goiter. About 30% may present with goiter with hypothyroidism, and some of them will present with compensated hypothyroidism. That means they still have normal T4 but elevated TSH. Less than 10% may present with a condition what we call hyperthyroid phase of Hashimoto's thyroiditis or toxic phase of Hashimoto's thyroiditis, and it is also known as hashitoxicosis. They have increased T4 just like you see in hyperthyroidism but suppressed TSH. This hyperthyroid phase of hashitoxicosis may last for about 3 to 6 months, and after that they become hypothyroid vast majority of the cases. So in order to make the diagnosis, obviously you have to do the free T4 or total T4 with TSH. Most of the people now do free T4, and the TSAs, then antibody which is diagnostic or characteristics of autoimmune thyroiditis is thyroid peroxidase antibody, which is present about 90% of the time. And anti-thyroglobulin antibodies also present very high titer, or maybe somewhat in the medium titer, but it's about 60% of the cases. But TPO is present is very high percentage of cases. The 10% of the cases they are negative. Either the antibody has been cleared from the system, or if you do the serial measurement of the antibody, you might find they might show up later on. If you do the thyroid scan, it will show the patchy uptake. So area of uptake followed by no uptake. And the British like to call them moth-bitten appearance. So scan is very helpful when you are trying to distinguish it from the Graves' disease, hashitoxicosis versus Graves' disease. And as I mentioned, that TPO and ATZ may be negative in the beginning but become positive as the time goes. If it is in low titer, it is a good idea to repeat that antibody in about 6 weeks, and then your titer will be much higher than you would like to see. So how about treatment-wise? Now, the treatment-wise, if the patient is euthyroid, T4 and TSH is still within the normal range but has positive thyroid antibodies. It is controversial, but most of the endocrinologists will not treat them with thyroid hormone replacement. And those who do, they believe that maybe by replacing the thyroid hormone, they will be able to keep the goiter at the bay, or it might decrease. However, long study shows that if the TSH is not elevated, the goiter may or may not decrease even on thyroxine. But it may decrease over the period of time without even any treatment. So this is a little bit controversial area. However, one thing that everybody will agree, the thyroid function must be followed every 6 months or so, because the condition will wax and wane. So therefore, thyroid function test, serial follow-up of thyroid function test is very important if you are treating or not treating. If it's a compensated hypothyroidism, by that I mean T4 is still within the normal reference range with elevated TSH, and I do believe the most endocrinologists will treat them with thyroxine because TSH stimulate the thyroid gland and make it bigger. And after years, some endocrinologists try to trial it off, especially when the requirement of thyroxine is low and patient TSH level is low normal range and antibodies has disappeared or negative. So in the situation they might taper it off and to see whether this will recur. However, long-term study also have found that if we don't treat them, this is my personal opinion, then if we stop treatment, then we need to follow them very, very carefully, not only for 6 months, not only the pediatric part of their life, adult as well. Because sometime after having a baby or a stressful situation, anxiety or tension, they may be back. So there are some older endocrinologists, they believe that once you start them on thyroxine, keep it for longer period of time or maybe lifelong. Therefore, you won't have to worry about developing a second hypothyroidism or lymphocytic or autoimmune thyroiditis, and which may be missed, and that increases the patient suffering. So I will leave that one up to the individual. The toxic phase of Hashimoto's thyroiditis almost always present with a diffuse enlarged thyroid, and it is non-tender. And clinically they are hyperthyroid, and with suppressed TSH, very hard to differentiate from Graves' disease clinically. And hyperthyroidism led to euthyroid state, but it might take anywhere between 2 to 6 months, and I have seen some report they have gone up to 1 year. But typically about 2 to 6 month time, they become euthyroid and ultimately hypothyroidism. And hypothyroidism occurs 50 to 60% of the cases. And in some cases, in the beginning, antibody may be negative, but if you continue to follow them serially, then antibody will be positive. And thyroid uptake will be another way of determining whether we are treating or dealing with Graves' disease or hashitoxicosis. Thyroid uptake will be low to low normal. As you know, in Graves' disease, thyroid uptake is high. So hashitoxicosis really does not need anti-thyroid medication, but they do require beta blockers. And depending upon their heart rate or degree of uncomfortability will determine whether you need to give the beta blockers, but it's a good idea and very safe to give beta blocker to make patient's heart rate reasonable and wait for the time when they will remit. And again, as I have mentioned before, follow-up thyroid function is extremely important. Finally, I like to finish my talk by showing the picture of Dr. Hikaru Hashimoto's, the great physician who described this condition in 1912. And so more than 100 years ago. And we still use his name to respect him. And so this is the picture of Dr. Hashimoto. Thank you very much.